Good morning, class. In continuation to yesterday's class, we will see today the second part of calcium homeostasis. So, the learning objectives for today's class are parathyroid hormone structure, synthesis, and secretion, and the physiological actions of parathyroid hormone, and vitamin D structure, synthesis, and release, and the biological effects or physiological actions of 125 dihydroxycholesterol or the active form of vitamin D, and calcitonin, the structure, synthesis, and release, and the regulation and actions of calcitonin, and finally the applied physiology or the applied aspects of these hormones. See, this is the triad of calcium homeostasis, so easy to remember. To regulate 3 and regulated by 3 and regulated at 3 sites. So what are the 3 things to regulate? It is calcium, phosphorus and bone, and regulated by 3 hormones, that is parathyroid hormone, calcitonin and vitamin D, and regulated at 3 sites, that is intestines, kidney and bones. Okay, so this is the triad of calcium homeostasis. So now we will see the first hormone, parathormone or parathyroid hormone. So this hormone is secreted by the chief cells of parathyroid gland. It provides a powerful mechanism for controlling extracellular calcium and phosphate concentrations. So this hormone is very important to maintain the calcium and phosphate homeostasis. So it increases the plasma calcium and decreases the plasma phosphate levels. So coming to the just physiological anatomy of the parathyroid glands, there are 4 parathyroid glands in the anterior aspect of the neck embedded in the thyroid gland. So these glands develop at 10th week of pregnancy from 3rd and 4th branchial pouches. So these glands derive blood supply from the thyroid arteries. So here again the picture, parathyroid located on the posterior side of thyroid gland. So this gland consists of 2 types of cells. One is chief cell and one is oxyphil cells. So chief cells are very predominant in the parathyroid gland, which are present throughout the life. They have Golgi apparatus in the cytoplasm and numerous vesicles and endoplasmic reticulum, which secrete the hormone parathyroid hormone. And oxyphil cells, they have no known functions and are very less in number compared to chief cells, and they appear in the glands during puberty, and then the number increases with the increasing age, and they contain oxyphil granules, but they do not secrete the parathyroid hormone, and also they sometimes they secrete parathyroid hormone, which will contribute to the excess of parathyroid hormone. Parathyroid hormone is a single-chain polypeptide containing 84 amino acids and molecular weight is 9,500. Like other peptide hormones, it is synthesized from large precursor molecule, that is pre-pro-PTH, pre-pro-parathyroid hormone, which contains 115 amino acids. The N-terminal signal sequence containing 25 amino acids is cleaved and pro-PTH containing 90 amino acids is released. Pro-parathyroid hormone on further cleavage releases parathyroid hormone containing 84 amino acids. PTH from 1 to 34, the amino acids from 1 to 34 has full biological activity, and PTH 25 to 34 is responsible for receptor binding. Coming to the functions of parathyroid hormones, it helps in the maintenance of blood calcium and phosphate levels, and it helps in the activation of vitamin D, and it acts on mainly bone, intestine and kidney. And the mechanism of action is through G proteins for parathyroid, and there are 3 types of parathyroid receptors, that is PTH1R, PTH2R and CPTH. So that is carboxy terminal of PTH. So in the cell, that this acts through cyclic AMP cyclase, that is adenylate cyclase cyclic AMP system, and IP3DAG system. So in the signal transduction class, you have seen that 4 mechanism of action of hormones are there. So in that adenylate, cyclic AMP pathway, and then IP3-DAG pathway. So this PTH acts through those mechanism of actions. So this is little more detailed functions of parathyroid hormones. It stimulates osteoclasts to mobilize calcium from the bone, and it helps in increased renal tubular reabsorption of calcium, and it inhibits the proximal renal tubular reabsorption of inorganic phosphate, and it indirectly induces an increase in intestinal calcium absorption, and it inhibits the proximal tubular reabsorption of bicarbonate, sodium, potassium, water, and amino acids. And it promotes bone remodeling, and low parathyroid hormones stimulate bone formation, and it indirectly increases intestinal calcium absorption by stimulating vitamin D synthesis. So it activates vitamin D, and it acts on bone, intestine, and kidney. So in kidney it inhibits the proximal tubular reabsorption of these things, and also inhibits the proximal tubular. So same here, you can add inorganic phosphate also here, and increases the renal tubular reabsorption of calcium. So as we know that maintenance of blood calcium level is the main function of parathyroid hormone. The normal blood calcium level of 9 to 11 milligram per deciliter is always maintained by the help of parathyroid hormone. So other things also help in maintaining the blood calcium level, but the primary one is parathyroid hormone. It increases blood calcium level by resorption from the bones and reabsorption from the renal tubules and absorption from GIT. So by these three mechanisms, parathyroid hormone increases the blood calcium level so that it is always maintained at 9 to 11 milligram per deciliter. So the hormonal effects on bone are in two phases, rapid and slow phase. So rapid phase action occurs within minutes and slow phase takes days to weeks. And the action on osteoclasts in rapid phase, it increases the activity of osteocytes, mainly osteoclasts, and already present increase activity of osteocytic pump. So already activated osteocyte, it increases those also. And formation of new osteoclast takes place in slow phase. And reabsorptive action of amorphous calcium salts and phosphate, that is osteolysis, takes place in rapid phase, and in slow phase resorption of bone itself leading to osteoporosis. And the actions of PTH on the blood calcium level and on the blood phosphate level. On blood calcium level, it increases bone resorption or absorption, and it increases renal calcium absorption in distal tubules, and it increases absorption of intestinal calcium. So on bone, on kidney and intestine. So in all these three, it increases the absorption. And on blood phosphate level, it stimulates resorption of phosphate from bone and increases urinary excretion, and it increases absorption of phosphate from GIT through calcitriol. So phosphate is resorbed from bone and increases urinary excretion. So here in kidney it is excreted, and from the GIT it is absorbed through calcitriol. So normal blood calcium is maintained by these actions. So when the blood calcium is increased, it suppresses the parathyroid hormone so that bone resorption is decreased, increase urinary loss, and decrease 125 dihydroxy cholecalciferol production or vitamin D production. So that leads to normal blood calcium. So the reason blood calcium is again brought back to decrease calcium, so that the level is always maintained at 9 to 11. So the same thing happens in reverse when the blood calcium falls. Bone resorption is done by osteoclasts, which are indirectly stimulated by parathyroid hormone. Osteoclasts do not have a receptor for PTH. So PTH binds to osteoblasts. Binding stimulates osteoblasts to increase their expression of rank ligand, that is receptor activator of nuclear factor Kb. So this is a member of tumor necrosis factor receptors and inhibits their expression of osteoproteogerin. So this is a decoy receptor of rank ligand and regulates the stimulation of rank signaling pathway by competing for rank ligand. So this rank ligand binds to receptor activator of nuclear factor kappa B on the surface of osteoclasts. So normally osteoproteogerin blocks the binding of rank ligand with rank, a receptor for rank ligand. So due to decreased osteoproteogerin, the binding of rank ligand to rank is increased, resulting in the fusion of these osteoclast precursors. The new osteoclasts enhance bone resorption. So finally, the bone resorption is increased with the uh, parathyroid hormone. So as you can see here, this is the bone marrow stem cell. So this is the rank ligand from the bone marrow adipocyte. So this is having the osteoclasts are having the receptors. You see here, osteoblasts are not having the receptors for parathyroid hormone and also the rank ligand. So these are the bone lining cells. So when the rank ligand binds to rank receptor, it activates the process of bone resorption by activating the osteoclast cells. So that is the effect of parathyroid hormone on bone. And now the effect of parathyroid hormone on kidney. So parathyroid hormone has three primary effects on the kidney. So the parathyroid receptors are present on the basolateral membranes of proximal and distal tubules. So through that receptors, parathyroid hormone enters the kidney cells and then shows its effects. So the effects are decreasing the loss of calcium ions in the urine by stimulating calcium reabsorption and inhibit the phosphate reabsorption. So this is the main thing, stimulating the calcium reabsorption and inhibits the phosphate reabsorption so that phosphate is excreted in urine. So increase calcium, decrease phosphate. And here it also helps in the production or stimulates the production of 125 hydroxycholecalciferol. So this formation of vitamin D is stimulated by the parathyroid hormone, and it also helps in increased reabsorption of magnesium and hydrogen and decreased reabsorption of sodium, potassium and amino acids. So these are the primary effects of parathyroid hormone on the kidney. So the effects of parathyroid hormone on blood, calcium and phosphate. So you can see the levels of calcium and phosphate and the parathyroid hormone secretion after 1 hour. So after 1 hour, when the parathyroid hormone secretion starts, the calcium level is increasing and phosphate level is decreasing. So this is the effect of PTH on calcium and phosphate. On the intestine, parathyroid hormone does not act directly, but it helps in the formation of 125-dihydroxycholecalciferol from the kidney, and through that it increases the calcium absorption. So this 125-dihydroxycholecalciferol activates the calcium binding protein, that is calbindin, and calcium stimulated ATPase is activated and alkaline phosphatase is produced. So through these three mechanisms, the calcium absorption is increased from the intestine. So this is a picture showing the regulation of calcium levels by parathyroid hormone. So hypocalcemia, as I have told you, it is a chief stimulus for parathyroid hormone secretion. So when the levels of calcium are decreased, it is sensitized by calcium sensing receptors. So these are the recently discovered receptors for the plasma calcium, which have been identified on the membrane of chief cells. Okay, in the parathyroid gland we have two types of cells, chief cells and oxyphil cells. So on the membrane of chief cells, these calcium sensing receptors have been identified. So these are a G protein coupled receptors attached to phospholipase C, and on binding with calcium it generates IP3 and DAG, that is the system mechanism of action of the parathyroid hormone. So when they sense the decreased calcium, they cause increased release of parathyroid hormone from the glands, and it will show its effect on the bone, kidney and intestine. So that will again lead to increased calcium, which will bring back the value to the normal. As we have seen in the previous slide, so the main regulator for the secretion of parathyroid hormone is calcium, and that too hypocalcemia. It is the most important stimulus for parathyroid hormone production and secretion. So in cases of hypocalcemia, there will be hypertrophy of parathyroid gland. Example in pregnancy, during lactation and in rickets. And in hypercalcemic states, there will be decreased activity and size of the parathyroid glands. Okay, so finally, the hypocalcemic state is the most important regulator or the stimulus for PTH production and secretion. Secretion of parathyroid hormone is controlled chiefly by serum calcium through negative feedback. So the calcium sensing receptors located on the parathyroid cells are activated when calcium is low. And then PTH is continuously produced and degraded. When the calcium is low, degradation is reduced and PTH is released. And when blood calcium is high, degradation is increased and PTH is not released. Secretion of parathyroid hormone is determined chiefly by serum ionized calcium concentration through negative feedback. Calcium binds to the calcium sensing receptors on the membrane of G cells, which results in activation of G protein coupled cascade through the activation of phospholipase C and IP3-DAG pathway is activated. It results in release of calcium from intracellular stores into the cytoplasmic space. It inhibits the release of parathyroid hormone. And PTH is secreted when calcium levels are decreased. PTH-RP is parathyroid hormone related protein. So it is very important specifically in some cancers. So this protein is having parathyroid hormone like activity. So that is, it is very much similar to parathyroid hormone in action via PTH1 receptors. It is having role in embryology and it is also secreted or produced by some tissues in the body. So it is seen in kidney and brain, but the function is not known, and it acts as a growth factor in development of skin and hair follicles, and it is the commonest cause of hypercalcemia in non-metastatic solid tumors. So it is also known as humoral hypercalcemia of malignancy, HHM. This point is most commonly asked as MCQ, and in practical viva it is also asked. So in up to 80% of cancer cases, there is hypercalcemia because of parathyroid hormone related protein. Commonly observed cancers are breast cancer, lung, renal and ovarian squamous cell carcinoma. So hypercalcemia is common in malignancy. In 80% cases, it is due to parathyroid hormone related protein. So the next hormone is calcitonin, which is secreted by the parafollicular or C cells of thyroid gland. And this hormone has effects exactly opposite to parathyroid hormone, and it is having very less role compared to parathyroid hormone in maintaining the calcium and phosphate homeostasis. It decreases the calcium level in the blood, and it is stimulated by increased serum calcium levels. Whereas the parathyroid hormone secretion is stimulated by decreased serum calcium levels. It is a 32 amino acid polypeptide secreted from the parafollicular cells, so it is also known as thyrocalcitonin. It is not secreted until the plasma calcium exceeds 9.5 mg per deciliter, and normal secretion is 0.5 mg per day, and half-life is 5 to 10 minutes or less than 15 minutes. It has having molecular weight of 3000, and normal plasma level is 0.2 nanogram per milliliter. And it is having actions on blood calcium, bone, kidney and GIT. So on blood calcium, it reduces the calcium concentration and it acts through adenylate cyclase cyclic AMP pathway. And on bone, it stimulates osteoblastic activity and inhibits osteoclast activity. So it decreases the osteoclastic activity, thus inhibiting the bone resorption, and it decreases plasma phosphate level because of inhibition of bone resorption and facilitation of phosphate entry into the bone. And on kidneys, it increases the excretion of calcium through urine, and it inhibits the reabsorption of calcium from renal tubules. So it causes calciuria, also produces mild phosphaturia by acting on the proximal tubule. So on kidney, there is a specific word called calcitonin escape. That is, injection of calcitonin produces hypocalcemia mainly by anti-osteoclastic activity. So the body escapes from hypocalcemic effects of calcitonin. This is called calcitonin escape. So the exact mechanism of which is not known clearly, probably due to down-regulation of calcium receptors. Therefore, calcitonin is effective in decreasing plasma calcium only for a short duration. This limits the use of calcitonin in long-term management of hypercalcemia. So on kidneys, here the point to be noted is calcitonin escape. That is, injection of calcitonin produces hypocalcemia mainly by anti-osteoclastic activity, but this anti-resorptive action begins to wane within hours. So that waning of the effect of calcitonin is called calcitonin escape, which is because of rapid downregulation of calcium receptors. And on GIT, it inhibits intestinal absorption of calcium and phosphate. And the prolonged effects of calcitonin are it decreases the formation of new osteoblasts, leads to secondary decrease in osteoblastic activity, and finally decrease the activity of both osteoclasts and osteoblasts. So this hypocalcemic effect is transient. And coming to the next hormone, that is vitamin D. It is having a potent effect to increase calcium absorption from the intestinal tract. Cholecalciferol, vitamin D3, is formed in the skin and activated by liver and kidneys. In the absence of parathyroid hormone, almost none of the 125-dihydroxycholecalciferol is formed. So I have told you in the PTH slides. So PTH helps in stimulation or activation of 125-dihydroxycholecalciferol. Several effects on intestine, bone, and kidneys. Vitamin D has effects on these sites, and it increases blood calcium and phosphate through increased absorption from intestine and decreased excretion by kidneys. So vitamin D helps in the maintenance of calcium and phosphate homeostasis through increased absorption from intestine and decreased excretion by kidneys. So recommended dietary allowance of vitamin D from infancy till puberty is 10 microgram of cholecalciferol or 400 international units of vitamin D, and in young adulthood it is 7.5 microgram, and after 25 years 5 microgram is required. Pregnancy and lactation 10 microgram is required. So the sources of vitamin D in human beings, it is from skin and also from diet. Dietary sources, as you all know, it is present in liver, fish, cod liver oil and milk. So a minimum of 2.5 grams micrograms of vitamin D should be ingested daily. And the recommended dietary allowance is 10 microgram or 400 international units. So from the skin, when it is exposed to sunlight through UV radiation of 290 to 315 nanometers frequency, it is converted to 7-dehydrocholesterol in the skin is converted to free vitamin D3. So in the coming slides, I will show you that. So see here, the UV light is helping in the conversion of 7-dehydrocholesterol to free vitamin D in the skin, and that is again converted to cholecalciferol, calciol, in the skin. So that cholecalciferol from the diet and from the skin is entering into the liver. Here hydroxylation of cholecalciferol takes place, converting it to 25-hydroxycholecalciferol. This is calcidiol. And then in the kidney, there is one more hydroxylation takes place, that is at the position of 24. So converting it to 24,25-dihydroxycholecalciferol. This is the inactive form. So it is calcitriol. So this is calciol, calcidiol, and this is calcitriol. And it is converted to the active form calcitriol by the addition of one position, further hydroxylation at one position, leading to 125-dihydroxycholecalciferol, which is the active form of vitamin D. So this is the synthesis of calcitriol from the skin and also diet. So in this picture, the cholecalciferol from the skin enters in the liver. It is converted to 25 hydroxylation, and in kidney 24 and also 1. So this parathyroid hormone is helping in the activation of inactive form to active form. And this vitamin D in the intestine, it helps in 3 ways. That is calcium binding protein, calcium stimulated ATPase, and alkaline phosphatase. So through these 3 mechanisms, it helps in the intestinal absorption of calcium, so that the plasma ion concentration is increased. So that is the effect on GIT, and its effect on bone. It stimulates terminal differentiation of osteoclasts, and it stimulates osteoblasts to mobilize the calcium. It stimulates the osteoblasts to stimulate the osteoclasts, which further mobilize the calcium, that it is by resorption. And on kidney, it increases reabsorption of calcium from DCT, that is distal convoluted tubule, and increases reabsorption of phosphate ion from proximal convoluted tubule. So finally, it helps in the reabsorption of calcium, so that it increases the level of calcium. So the actions, as I have already explained you, on intestine, it increases the absorption of calcium and increases synthesis of calcium-induced ATPase in the intestinal epithelium, and it increases the synthesis of alkaline phosphatase in the intestinal epithelium, so that it helps in the calcium absorption, and finally increases the absorption of phosphate from intestine. So this is the picture showing maintenance of calcium homeostasis by various hormones, that is the parathyroid hormone from the parathyroid gland, and calcitonin, and vitamin D. So this is a little bit confusing, but everything like parathyroid hormone and the effects of calcitonin and the effects of vitamin D. So if you draw on your own, you will be able to remember very much. So try to observe the things here. Parathyroid effects on kidney, and then how the parathyroid hormone is produced, calcitonin, how it is stimulated, and what are the effects of calcitonin on bone, and then what are the effects of vitamin D on kidney and intestine and bone. So like that, for each and every hormone, if you see its mechanism of action and the effects on bone, intestine, and kidney. So you can easily tell about the calcium homeostasis. So again, decreased plasma calcium or hypocalcemia is the main stimulus for parathyroid hormone secretion. So that will cause increased calcium reabsorption from kidney and increased 125-dihydroxycholecalciferol formation, and in bones it helps in increased resorption of calcium, leading to again finally restoration of plasma calcium towards the normal value. So this is again one more pictorial representation. Like this chart you can prepare on your own, so that you will be able to remember the effects of these hormones on various organs and on the calcium and phosphate homeostasis. So PTH action on bone, it causes bone resorption, and 125 DHCC, that is vitamin D, it mobilizes calcium and phosphate from the bone, and calcitonin, bone resorption decreases. And on GAT, calcium and phosphate absorption increases, and vitamin D absorption increases, calcitonin absorption decreases. On kidney, phosphate absorption decreases by PTH, calcium reabsorption increases, and vitamin D, calcium resorption increases, and calcitonin, it decreases 125 dihydroxycalciferol, and calcium and phosphate excretion increases. And on serum calcium, the effect of PTH is increased, and vitamin D causes increased calcium, and calcitonin decreases the calcium. And on phosphate, the effect of PTH is decreased phosphate levels, and vitamin D causes increased phosphate levels, and calcitonin causes again decreased phosphate levels.
So, applied physiology of parathyroid glands. The two types of parathyroid disorders are present. One is hypoparathyroidism and other is hyperparathyroidism. So hypo means, as you all know, decreased parathyroid hormone secretion. The causes for that is parathyroidectomy, thyroidectomy, and deficiency of receptors for parathyroid hormone. And hyperparathyroidism is of three types: primary, secondary, and tertiary hyperparathyroidism. So in hypoparathyroidism, we have hypocalcemia, hypocalcemic tetany. So the signs and symptoms are hyperreflexia and convulsions. So the reflex activity of the body are increased and the convulsions are present. So that is because of decreased calcium in the serum. And the carpopedal spasm, that is carpal and pedal, hand and feet. Contractions, unrelieved and strong contractions of the muscles of the hand and foot. Laryngeal shudder is again contraction of laryngeal muscles, and some cardiovascular changes like decreased heart rate and contractility of the heart muscles, and some other features are seen. And in late or subclinical tetany, we have Troster sign and Chostek sign and Earp sign. So these signs are nothing but eliciting the spasm, carpopedal spasm, and then Chostek sign is eliciting the facial spasms. So these signs, if you have not understood clearly, so just check in the dictionary, medical dictionary, they are present. So if you type in Google hypocalcemic tetany, these all will come, and these are present in any textbook. And the hyperparathyroidism causes hypercalcemia, and the signs and symptoms are depression of the nervous system, sluggishness of reflex activities, reduced ST segment and QT interval in ECG, lack of appetite, and constipation. The parathyroid function tests are measurement of blood calcium level, eliciting the Chvostek sign and Rosser sign for hypoparathyroidism. And the next condition is pseudohypoparathyroidism. In this, the patients have normal parathyroid glands but fail to respond to parathyroid hormone or parathyroid hormone injections. And it is autosomal dominant type. And the symptoms and signs are hypocalcemia, hyperphosphatemia, and the characteristic physical appearance, that is short stature, round face, and short thick neck, obesity, and shortening of metacarpals. And the persons have resistance to parathyroid hormone. Symptoms begin in children of about 8 years, and the symptoms are tetany and seizures or convulsions, hypoplasia of dentin or enamel, and delay or absence of eruption occurs in 50% of people with the disorder. And the treatment for this condition is vitamin D and calcium, adequate amount of phosphorus in the diet. So this is pseudohypoparathyroidism, which begins in the children of about 8 years. And the symptoms are tetany and seizures and hypoplasia of dentin. And the treatment will be vitamin D, supplementation of vitamin D and calcium, and also phosphorus in the diet. And osteoporosis is a condition when the calcium content of the body is decreased. So it is a disease that makes bones more fragile and is responsible for more than 1.5 million fractures annually. And that fractures include vertebral fractures, hip fractures, and wrist fractures. These are the most common fractures observed annually in the whole world. Bones naturally destroy and rebuild themselves over a lifetime, and this is the picture in a healthy bone. And in people with osteoporosis, bone become quite porous like this. Here you can see the bony part is very much decreased, and the empty spaces are present more. So this is also again the picture of normal bone and osteoporotic bone. So the bony content is decreased and porosity increases so that the bone will be easily breakable. Next is primary hyperparathyroidism. This is seen especially in women that do postmenopausal and are more commonly affected than men. And the causes are sporadic adenomas and multiple endocrine neoplasia type 1 and parathyroid tumors. So men 2A, that is multiple endocrine neoplasia type 2A. In that, parathyroid tumors, medullary thyroid cancer, and pheochromocytoma. And familial hyperparathyroidism. This is primary hyperparathyroidism without other tumors seen in MN1 and 2A. So MN1, 2A, these have combined. In type 1, we have parathyroid tumors along with pituitary and pancreas. In type 2A, we have parathyroid tumors along with thyroid and pheochromocytoma is adrenal medullary tumor. And familial benign hypocalciuric hypercalcemia. So these two are the familial types of hyperparathyroidism. One is sporadic adenoma and then other is men type 1 and 2A, and other two are familial hyperparathyroid. This condition is characterized by increased serum calcium and decreased serum phosphate, and increased urinary phosphate excretion and decreased urinary calcium excretion, and increased urinary cyclic AMP and increased bone resorption. And the osteoblastic activity increases in an attempt to make further resorbed bone. They secrete large quantities of alkaline phosphatase. And the clinical features of this condition, it's said in a rhyming sentence like painful bones, renal stones, abdominal wounds, and psychiatric wounds. So the pain of bones is due to fracture of bones. So easily the bones are able to get fractured, and the renal stones are nephrolithiasis. They occur with pain and obstructive uropathy. And GI disturbances are constipation, pancreatitis, nausea, and peptic ulcers. And CNS symptoms are depression, lethargy, and seizures. Neuromuscular abnormality including weakness and hypotonia. So the patient complains of painful bones and renal stones, and also renal stones because of that pain will be present, and abdominal wounds, that is pancreatitis, constipation. So pain also will be present because of constipation, and psychiatric wounds are because of depression, lethargy. And the radiological features of this condition is subperiosteal resorption of phalanges of index and middle fingers. So in the fingers, okay, index and middle fingers, in the phalanges there will be subperiosteal. So finger in the first fingers of the hand and feet. Uniocular and multilocular cystic radiolesions are seen in bone, and generalized attenuation or loss of lamina dura surrounding the teeth, and decrease in trabecular density and blurring of normal trabecular pattern, giving ground glass appearance. And treatment for the condition is hyperplastic parathyroid tissue or functional tumor is removed surgically to reduce the hormone levels to normal. The secondary hyperparathyroidism, it results in excess secretion of parathyroid hormone due to Parathyroid hyperplasia compensating for a metabolic disorder that has resulted in retention of phosphate or depletion of the serum calcium level. So it results in excess secretion of hormone due to hyperplasia of the gland, which compensates for a metabolic disorder that has resulted in retention of phosphate or depletion of serum calcium. So the primary condition is a metabolic disorder which causes retention of phosphate or depletion of serum calcium. So that secondarily the parathyroid hormone is secreted in excess. So this is secondary hyperparathyroidism. And the renal osteodystrophy refers to skeletal changes that result from chronic renal failure. In patients with secondary hyperparathyroidism caused by end-stage renal disease, striking enlargement of jaw occurs. So this is the enlargement of jaw. Palatal enlargement is a characteristic of renal osteodystrophy associated with secondary hyperparathyroidism. And bone lesions are present in digits and clavicle, mottling of skull and erosion of distal clavicle, rib fractures and necrosis of femoral head are also present, and in children there will be osteomalacia. Treatment is restriction of dietary phosphate and use of phosphate binding agents like calcium carbonate or calcium acetate, and use of calcium mimetic agents like cinacalcet, and treatment with an active vitamin D metabolite. Synthetic salmon calcitonin can be used, and renal transplant is the ideal treatment. So main goal of the treatment is to reduce the dietary phosphate or use of phosphate binding agents, and also increase the calcium level by giving the supplements. And coming to the vitamin D deficiency disorders, so first one is Rickets. So this is the most common condition you all know in your intermediate. So it mostly affects the children, and the site is on the bones, and the pathology is because of calcium phosphate deficiency. So the dental findings in rickets are hypoplasia or hypocalcification. So there will be increased width of predentin and poorly calcified enamel, and odontoblasts are also seen. So this is pigeon chest deformity. The children will have deformity, chest will be enlarged, so which will be looking like pigeon chest. And rachitic rosary. So this is the rib structure, so which will be appearing like a rosary. So the prominence of ribs can be seen easily from the outside. And knock knees and bow legs. So the legs are like a bow or knock knees. Knock knees means like they will be coming closer together at the ends, and the borders will be in a concave shape. So it is called knock knees or bow legs. So here this is lumbar lordosis and Harrison sulcus. So the increased convexity is present in the thoracic part, and then concavity is present in the cervical and lumbar region. So this is called lumbar lordosis. And the Harrison sulcus is in this picture. You can see this is the Harrison sulcus, and all these are the features of the rickets. So rachitic rosary, pigeon chest deformity, lumbar lordosis, and the hypocalcification of the dental teeth. And then with osteomalacia or adult rickets, the amount of mineral accretion in bone per unit bone matrix is deficient due to inadequate absorption of calcium and decreased amount of phosphorus owing to deficiency of vitamin D and C in the diet. So this is in the adults there will be decreased concentration of vitamin D and C in the diet. So that will be leading to deficient absorption of calcium and decreased amount of phosphorus in the blood. So it is limited to females usually after multiple pregnancies and lactation, but symptoms tend to clear up after lactation is completed. And the bones especially are pelvic girdle, ribs and femur become soft, painful and deformed. So it is seen in adults after closure of epiphyseal plates, impaired mineralization of osteoid matrix, leading to fractures and bending of bones and widening of osteoid seams. So this is the most characteristic features. Laboratory tests are low serum calcium and phosphorus are seen, and high alkaline phosphatase activity is seen. And in radiograph, there will be diffuse lucencies of the bone. So empty spaces, you can see the darker areas are the lucencies. So in today's class, we have seen the hormones which are responsible for regulating the calcium and phosphate homeostasis. That is, parathyroid hormone is the main hormone, and then the minor hormones are calcitonin and vitamin D. So we have seen their synthesis and secretion and physiological actions and regulation of the hormone secretion. And also lastly, we have seen the varied applied aspects, that is hypo and hyperparathyroidisms, and then the vitamin D deficiency diseases. So that's all. Thank you all for the patient listening.